Dr. Gulshan, another 5 seconds.
Yeah.
Live.
Good evening, everyone, and a very warm welcome to this session of Male Infertility Crash Course. We have with us today Dr. Kedar Gandla, Consultant Fertility Physician and Honorary Secretary, Isar. Over to you, Dr. Kedar, to take the session forward.
Good afternoon, good evening, everyone. And it's my proud privilege to introduce Dr. Kishore Nadkarni, who has been working in the area of male infertility since last 3 decades. He's a director of Nadkarni Hospital Test Baby in Killa Pardi. It's called 21st Century Hospital, Vapi, Surat, consultant surgeon, male infertility specialist, running a clinic called Androford, Male Also Matters, conducted 7 state level and 3 international conferences on ART and endoscopy, over 40 publications and textbook chapters, and most important, he is a PG students and interested in teaching PG students since last 17 years. Over to you, Kishore. Kishore is going to talk to us about medical management of male infertility.
Thanks,
Kishore,
Kedar.
you can go. Yeah.
Yeah, can you hear me clearly?
Yes, very clearly, Kishore.
Okay. Greetings from Gujarat. We are going to talk on the medical management of male infertility. Male infertility affects 9% of the male population.
So you'll have to start your share screen. Your presentation is not shared.
Can you hear me?
You're audible, sir.
Okay. Shall I start then?
So we cannot see your presentation. You'll have to put on your share screen. And there's an icon at the bottom.
Can you see it now? Can you?
Yes, sir.
Okay. So greetings from Gujarat. I'm going to speak on medical management of male infertility. As you know, male infertility affects 9% of the male population, and 50% of the couples coming to our OPD for infertility have a male factor. There is a marked regional variation in different states of India, and particularly in Western India, Gujarat, we have as high as 65 to 70% male factor. In our clinic, we see almost 5 to 7 patients daily of male and even 2 to 3 patients of azoospermia. This is probably due to an increased tobacco consumption. We have a large consumption of gutka in our area. 1% of all males suffer from azoospermia, and 3 out of 10 male patients coming for infertility have azoospermia in our center. Now, evaluation of male factor is centered around a patient's semenogram. We usually see the patient take his history, but we also ask him to come get a semen report done. A good standardized semen analysis report, at least 3 reports, and we review all the previous reports and make a chart of that. With an abstinence period of at least 2 days is the most basic investigation. Semen analysis has a sensitivity of nearly 90%, and we rely on it as a marker for male infertility. Serum FSH, serum testosterone, and DNA fragmentation tests also provide information regarding testicular function and sperm DNA damage. As you know now that the 5th percentile values are the minimum values required for fertility: 1.5 ml volume, 7.2 pH, 12 to 16% concentration, a motility of at least 31% progressive, and a morphology of at least 4%, a 58% vitality, and a WBC of less than 1 now, 1 in 10 squares of the macular chamber. and 50% of antibodies. Total motile count we always do in all the cases, and it is usually written on the lower left-hand side of the semen report, and it's the count multiplied by volume multiplied by motility. Now, oligoasthenoteratozoospermia, as you know, is a category of subfertile males where all the three parameters of sperm function are affected, namely concentration, motility, and morphology. And generally, most of our patients who come to the OPD have one or more parameters altered, and they would fall into the category of OATS, mild, moderate, or severe. The common causes of OATS are varicocele and genital tract infections, which we try to rule out first. In evaluation of the infertile male, we ask for history of undescended testes, history of tobacco, alcohol, drugs, exposure to venereal disease, history suggestive of filariasis, trauma, heat exposure, any operations done particularly in childhood, mumps, typhoid, orchitis, problems of intercourse, consummation of marriage, erection, orgasm, masturbation, frequency of intercourse. So a detailed history and as well as sexual history is taken, and history of all the risk factors is included. In examination, we do a general examination for endocrinopathy. We look at the general height, weight, the obesity, and also gynecomastia, axillary hair, pubic hair, etc. And we look for the testicular size and the position. We look for a turgid epididymis, particularly in obstructive azoospermia. We examine the vas and epididymis, and a rectal examination is also done for seminal vesicles and prostate. Scrotal skin, penis, phimosis, hypospadias, epispadias, etc. is looked for, and hernia, hydrocele, and varicocele is ruled out. I already told you this: masculinization, sex, secondary sex characters. Testicular volume, usually 18 to 24%. We use an orchidometer or simply a foot ruler, a simple plastic ruler. The vertical length of the vertical axis of the testes, if it's more than 4.3 centimeters, it is normal. The epididymis is either flat or turgid, and presence or absence of vas deferens. This is the Prader orchidometer. We have another one. I think Ames orchidometer is the one that we use. And in the investigations, at least 3 reports of semen with an abstinence of 2 to 3 days. Count, motility, morphology, according to the strict Kruger's criteria, viscosity, liquefaction, and we centrifuge and examine the pellet in case of azoospermia. Investigations, we do routine blood counts. We always do sugar and creatinine. We are able to detect a lot of borderline kidney decompensations as well as diabetics. The blood group VDRL, HIV, HB, SAG, and FSH and testosterone we do in all cases of male infertility, even if one semen parameter is altered. And in cases of severe oligospermia and azoospermia, we also do LH, prolactin, and estradiol. Anti-sperm antibody tests are done, like IBT-MAR, and testicular biopsy is not done routinely. But in cases of azoospermia, we have now started doing needle biopsies of the testes, a live needle biopsy to also see the sperms, retrieve the sperms, and then send the tissue for histopathological examination. American Urology Association recommends serum FSH, testosterone in all cases of initial hormone assessment with prolactin, estradiol, and LH in severe oligospermia and azoospermia. An elevated FSH level greater than twice the normal limit is a reliable indicator of abnormal spermatogenesis and severe testicular dysfunction. However, focal areas of spermatogenesis may be present in patients with highly elevated FSH, and that is the basis of a micro-TSA. Recently, a stronger correlation has been demonstrated between inhibin B and spermatogenesis. Now, what is the rationale of treating male factor? The rationale is that in borderline sperm counts, aim is to try and improve semen parameters and achieve a pregnancy by natural methods or IUI, and thus avoid an inevitable ART outcome. Specific treatment is indicated when the specific cause is known and it is outlined. Non-obstructive azoospermia requires specific pre-treatment to improve chances of sperm retrieval. We now have nearly 75 cases of such cases which we have put on treatment. Empirical treatment is given in all other cases of male subfertility with altered semen parameters to improve the reproductive outcome. Now let us go on to the specific therapy. First is hypogonadotropic hypogonadism. Low FSH, low LH, low testosterone. Usually the testicular volume is small, 20 to 30%. There may be azoospermia or a severe oligospermia. Many of them have sperms in the ejaculate. And here the treatment is actually of two types. One is for steroidogenesis and the other is for spermatogenesis. I'm going to tell you the treatment that we give for spermatogenesis. We give gonadotropin therapy with HCG 2000 units 3 times a week for 6 months. And at the end of 3 months, we supplement it with Rec FSH 150 units 3 times a week for the later 3 months. And this is good enough to induce spermatogenesis in many patients. In large percentage of cases, more than 50% of the cases do get sperms with this treatment. Borges et al. Has reported 80% of azoospermic men to have sperm in their ejaculate in a median time of 5 months. Of course, in many patients cannot afford Rec FSH 150 units. In these cases, we give urinary FSH for 3 months. Therapy should be started 6 months prior to planned fatherhood. If they don't have sperms in hypo, we give treatment for 6 months before we attempt a sperm retrieval. Lot of evidence available. Gonadotropic treatment starts with administration of HCG. As we all know that HCG is required for spermatogenesis. You have to prime the testes, the germinal follicles with HCG. Whereas HMG or Rec FSH added later on is responsible for spermiogenesis, that is the maturation of the sperms. But HCG is a must, so treatment is always started with HCG and then later on HMG or Rec FSH or urinary HMG is added. The two important things here is the rigid discipline is needed because both compliance and cost, these are important. So in my patients, I usually get it directly from the company and I'm able to give them HCG at a very low rate and also give them HMG at a very low rate. So they are able to complete the entire treatment of 6 months within 40 to 50,000 rupees. Now, leucocytospermia, the second specific cause where the cause is known. This is presence of pus in the semen or pus cells in the semen. This is characterized by pus cells 1 into 10 raised to 6. Neutrophil granulocytes need to be differentiated from round cells and immature sperm cells, and hence a stained smear is always done. The WHO cutoff is 1 into 10 raised to 6, and recently a lower cutoff has been suggested that even 0.1, that is 1 leukocyte in 100 squares of the macular chamber, is enough to qualify for leukocytospermia, enough to give reactive oxidant species to cause sperm DNA problems. Usually it is due to prostatitis and seminal vesiculitis, that is the accessory gland infection. Semen cultures we usually do because patients have now started asking, are you doing cultures and antibiotic sensitivity? Leukocytospermia causes production of reactive oxidant species and free radicals, which cause sperm DNA fragmentation and reduce sperm motility. The common organisms are E. coli, ureaplasma, chlamydia, klebsiella, and pseudomonas. And the antibiotics used are doxycycline, quinolone, Micc and azithromycin. My personal preference, I always start with doxycycline and then usually give plurifloxacillin, because I read 2-3 reports of plurifloxacillin among the quinolones giving very good results. And azithromycin, of course, is nowadays favored. Two important things. One is according to body weight, you have to increase the dose. If the patient is 100, 120 kgs, maybe double the dose. And 150 kgs, we have many patients with 150, 160 kgs. So they need a much higher dose. And the duration should be at least 14 to 21 days. And in resistant cases, I give Micc injections, 500 milligrams twice daily for 10 to 15 days. 15 days, usually 2 weeks. And in addition, in very resistant cases, I give intraurethral injection of diluted Micc in 10 ml of distilled water by a simple needle, simple syringe, which is attached to the meatus, and you carefully push the distilled water with Micc inside. Results of treatment are satisfactory and usually result in increased sperm counts. Antibiotic therapy is usually combined with antioxidant treatment. Of course, in many of these patients, DNA fragmentation tests have been done, and we can use that as a marker or as a prognostic indicator. In the literature, of course, most of the antibiotics give 70 to 80% success rates and uniformly good success rates. So I think cost again is important here. Hyperprolactinemia we are seeing quite routinely, and the treatment is, of course, cabergoline. Nobody uses bromocriptine anymore, but cabergoline 1 milligram per week. I give 0.5 milligram twice weekly for 1 month. It is very strong. It causes drastic reduction in prolactin levels. And sometimes in 15 days, the prolactin levels come back to normal. If the prolactin levels are more than 100, we look for a microadenoma. And if it's more than 250, we also look for a macroadenoma. Immunological infertility as detected by, confirmed by antibodies, IgG, IgM antibodies detected by MAR test. And we give prednisolone in tapering dose. I'm a little scared to give 160 milligrams of prednisolone. I give isolone 20 or 40 milligrams depending on the body weight, 4 times a day, 3 times a day, twice a day, and once a day, tapering over a 2 to 3 month period. In erectile ejaculatory dysfunction, that this is the last specific cause of infertility. The commonest thing that we encounter is inability to give the sample, and we give in situational ejaculation, they are unable to give the sample. This can be prevented by simple methods like a comfortable room, putting a don't disturb sign on the room, accompaniment of the partner, sometimes getting the sample from home if they are able to get it in time. Masturbation with visual stimulation, you can use vibrators sometimes, coitus interrupters with silastic condoms, and use of stimulants like Viagra. I usually give Zydalis Express. Now you have not Zydalis, which is the Tinagra Express. It's a sublingual mouth dissolving tablet of sildenafil. But I usually, these patients who are unable to give, I usually ask them to take 10 milligrams of tadalafil on the previous night, and in the morning I give them sublingual or some dissolving sildenafil. This is the kind of vibrator that we use. Electro ejaculation, I don't have this instrument. We have not done it here in our hospital. Now we come to non-obstructive azoospermia. Patients with azoospermia who have testicular failure or hypergonadotropic hypogonadism. Classically, these patients have a raised FSH. The testosterone may be normal or may be low. However, it is believed that there is an imbalance between the circulating testosterone and the estrogen levels, with the lower intratesticular levels of testosterone with a T to E ratio of less than 10. Now, in many cases, we are able to get T to E ratios less than 10. But simply doing testosterone also gives us an idea. If the total testosterone levels are less than 250, 300 actually is the cutoff, but if it's less than 250, I give them HCG injections, 2000 international units, 3 times a day. I have now 75 patients, who on such therapies in non-obstructive azoospermia prior to retrieval. Initially, we used to do the retrieval because the gynecologists used to almost give me hardly any time to treat the male. Now we do we give this treatment and we do a needle biopsy as well, because we give aromatase inhibitors in these patients, because aromatase inhibitors, as usual, as you know, prevents the conversion of testosterone to estradiol and therefore increases the intratesticular levels of testosterone. And 2 to 3 months, Adova or letrozole. These are the two preferred aromatase inhibitors. I usually give Adova and sometimes letrozole. As you know, the cholesterol pathway, pregnenolone, progesterone, 17-dihydroprogesterone, androstenedione, and then testosterone. And then, as you know, a lot of it gets free testosterone and bound testosterone to albumin globulin, and much of it gets converted to DHT by the enzyme 5-alpha reductase, and the other testosterone goes into the aromatase pathway to get converted to estradiol. A lot of evidence in literature all started, I remember, I think it was Amsterdam, Cornell. They had a huge session for this aromatase inhibitors and gonadotropins in non-obstructive azoospermia. It was in 2009, I think, in Amsterdam. And it was very interesting at that time. And we started giving these treatments at that time. A lot of evidence in literature. Anastrozole, Raman and Shelgel evaluated effects of anastrozole. And all treatment groups had a statistically significant increase in T2E ratios and improved semen parameters. Letrozole, many studies by Cavallini et al. And Salem et al. Definitely showed increase in testosterone levels, and also some of them did have sperms in the ejaculate as well. You need to give it for some time. Gorgio et al. Treated some 29 men with low T2E ratios for a period of 6 months with letrozole 2.5 milligrams, and with very similar increases in total testosterone and decrease in serum estradiol was observed. Increases in sperm concentration and morphologically normal sperms in the ejaculate were also seen in patients treated with letrozole and anastrozole. There are, as you know, the aromatase inhibitors can be steroidal and non-steroidal, and steroidal we are not using. It's not available here in our area. Testolactone 50 to 100 milligrams per day. and anastrozole, tamoxifen, and letrozole, of which anastrozole and letrozole are popular. Best results were reported with anastrozole 1 to 2 milligrams in combination with HCG for a period of 4 to 6 months as compared with testolactone with HCG, which had 54% results. Now, gonadotropins in NOA. In non-obstructive azoospermia, people with the negative TESI sometimes insist on giving their own sperms. They say, please try again, please try again. Of course, we try to cause as minimum damage to the testes while doing the TSA. And if they want a repeat testes, we usually put them on this treatment. This treatment has been recommended by Shiraishi et al. The rationale of this treatment is high levels of exogenous gonadotropins suppress or reduce endogenous gonadotropin secretion, which results in resetting of the FSH and LH receptors in the Leydig cells. Shiraishi et al. Gave 5,000 international units of HCG 3 times a week to 28 patients of non-obstructive azoospermia with negative TESI. And if the FSH declined after 3 months, he gave rec FSH 150 international units 3 times a week for the next 2 months. This resulted in a second successful TESI in 6 patients. A lot depends on the histopathology. In most of the things, even in varicoceles, even in gonadotropins, even in aromatase inhibitors, if the testicular biopsy shows hypospermatogenesis or late maturation arrest, then the chances of the sperms coming are good. If it shows Sertoli cell only syndrome or early maturation arrest, the chances of all these things acting are very less. Now let us go. These are the specific conditions where we give treatment for in male infertility. Now let us go on to empirical medical management of male infertility. Now we all know we give anti-estrogens. Many people give clomiphene citrate and letrozole to patients with empirical subfertility with low counts and low motility. What is the rationale? The rationale is anti-estrogens. So they reduce the circulating estrogens and thereby by negative feedback stimulates FSH and LH. FSH causes spermatogenesis, but the LH stimulation sometimes precedes the FSH stimulation, resulting in spikes of testosterone levels, which in turn suppress FSH or suppress spermatogenesis. So this is important to know. So not everybody gets good results. There is level 1 evidence only. There is no evidence-based medicine does not give us tell us that you should use these drugs. Limited results have been reported. There are a lot of publications of anti-estrogens as well as gonadotropins. Now, which patients will you give anti-estrogens? Patients with low counts, low motility, with low FSH and low testosterone. These are candidates where you can give clomiphene citrate, and you can give it for about 3 months, and you can try and see. But you should monitor testosterone levels as well as sperm levels as well, because if it's giving negative results, you should stop the clomiphene citrate. Same with gonadotropins. Empirically, in patients with subfertility with low counts, can you give HCG and HMG? You can give, but again, evidence does not indicate the benefit of these. There's very little evidence to show that HCG and HMG injections benefit these patients for empirical management. Again, here the same principle, and monitoring of testosterone levels is important. Testosterone is not used. We do not give testosterone directly because it can lower FSH and LH and thus inhibit spermatogenesis by negative feedback. And Jacquard, very early in 2003, in her book, has written that 6 to 10 injections of testosterone given daily can render a normospermic male azoospermic. Now, antioxidant therapy, favorite of everybody. Everybody gives antioxidants. Why are they given? To counter the reactive oxidant species. Now, what are these reactive oxidant species? Reactive oxidant species are free radicals of chemical intermediates that have 1 or more unpaired electrons. Now, in the course of energy production in the sperm mitochondria, free radicals like -OH, -O2, etc. are formed, and these are normally scavenged by dismutases, by glutathiones, by normally in the body, tocopherols, etc. Excess of ROS leads to cellular dysfunction. Now, what does this cellular dysfunction do? It usually first affects the cell membrane and causes toxic lipid peroxidation of the cell membrane. It then goes on to the mitochondria and affects the mitochondrial DNA, RNA, and reduces energy production. And later on, it causes DNA damage, the nuclear DNA. And this DNA damage may be in the form of single or double strand breaks, nucleotide modifications, base loss, aberrations in chromatin packing, and telomere shortening. most of these things, drugs, smoking, fever, cancers, systemic infections, act through the mechanism of reactive oxidant species. Most of the problems that affect the sperms or spermatogenesis act through reactive oxidant species. Of course, leaving the genetics apart, genetic causes apart, through reactive oxidant species or through increase in inhibin B, that is endocrine dysfunction. All these chemicals which we are exposed to, they are also responsible. Personal care products, plastics, the industry solvents, the contamination of water, endocrine disrupting chemicals, pesticides that we use in plants, all of these plastic products, bisphenol A, bisphenol S, these are chemicals which are used to harden or soften the plastic. That is why the plastics are now being shunned, and they are also responsible for infertility to some extent. Now, how do you manage ROS related infertility? Basic management of ROS related infertility is lifestyle modification. You have to control the obesity, reduce the weight, reduce alcohol, prevent smoking, do not consume tobacco, have a good diet, reduce stress, have good sleep, avoid activities hitting the scrotum, use proper ventilation, use personal protective equipment if you are staying in highly polluted areas. Like, for example, even in Vapi or in Ankleshwar in Gujarat, we have very high levels of chemical fumes particularly in the night, smog. And so we have to really care. You might even have to relocate for that matter. And of course, treat the infections, that is leucocytospermia and varicocele. So if you do all this, and in addition, you can give vitamins, food supplements, and antioxidants. So all these together constitutes the management of ROS related infertility. Now, antioxidants like vitamin A, D, C, E, alpha tocopherol, biotin, thyroxine, levocarnitine, coenzyme Q10. Now, in abroad, I have seen they're using plain vitamin E, they're using vitamin C, they're using this. But nowadays, I attended a lot of lectures by our own Ashok Agarwal as well as Mohammad Reza. These are the two people who gave us a lot of evidence regarding levocarnitine, acetyl levocarnitine, and coenzyme Q10. Now, combination of these drugs are available in India. We have lots of combinations in the form of powders as well as in the form of they reduce oxidative stress, scavenge free radicals, and reduce DNA damage. They stimulate mitochondria and increase energy production and stabilize the cell membrane. Different preparations, as many as 120 preparations we counted available in the Indian market. What is important is the dose and the combinations, what dose of each. Coenzyme Q10, at least 200 to 300 milligrams, levocarnitine, 1 to 1.5 grams, astaxanthin, 8 milligrams, zinc, 30 milligrams, lycopene, 5,000 to 8,000 micrograms, folic acid, 1,000, B12, 1.5 micrograms, selenium, 1,000 micrograms, 100 micrograms, L-arginine, 3 to 5 grams, and citric acid, 100 milligrams. I personally give 300 milligram CoQ, and in addition, I give a sachet which contains all the remaining ingredients. So more or less, this is covered. Empirical antioxidant therapy may be given for up to 2 to 3 months, as the spermatogenesis cycle is of 63 days. Usually 45 days is spermatogenesis and the spermiogenesis is the other 18 days. There is now emerging evidence on the benefit of CoQ 300 and carnitine and acetyl levocarnitine in increasing sperm motility. Lot of evidence available, Bingham et al., Agarwal et al., Buran et al., showing improved results with improved IUI results with and even natural pregnancies with DI5 and improvement in DI5 values. Bangam et al., Zini et al., a large study of 2,549 ICSI cycles and meta-analysis 2011 and 2016 evaluation of all these reports showed that oral antioxidant supplement used in male infertility can help to increase the pregnancy rates. So to conclude, my dear friends, specific medical management when indicated should be instituted. When specific cause is not known, what you give treatment is called empirical medical therapy. And in many of us are called upon to give some treatment to people to improve their counts. This is known as empirical medical treatment, which I have outlined. There is emerging evidence on the role of antioxidants in ROS-induced OATS, and this may be given for 2 to 3 months. There is a specific indication for medical management in non-obstructive azoospermia. Again, level 2 they say, but evidence. But we are doing a study, our own study. We have now results, encouraging results are coming. and medical management should be given along with IUI and ART options. Thank you very much. Can you hear me?
Dr. Kedar?
Thank you so much, Dr. Nadkarni, for the wonderful presentation. Dr. Kedar, may I please request you to introduce the next speaker now?
Dr. Vasan is the uroendocrinologist, one of the leading speakers of on male infertility. He's CEO and medical director of Ankur Clinic in Bangalore, head of Endology Fellowship Program, and he's a teacher in Rajiv Gandhi University Health Sciences. And he's a co-founder of Janani, a startup for transforming the fertility programs. Endology invitation, he's got many of them. He's got some sperm media and made in India project. So well, we are going to hear somebody who is going to be an uroendocrinologist is going to talk to us about surgical management of male infertility. Thank you. Thank you, Vasan. Now you can start off.
Thank you, Kedar, for that introduction, and thank you, Isar, for this wonderful opportunity. And at the outset, I think Kishore did a brilliant job of summarizing the various medical management strategies. Now, I'll briefly touch upon what are the surgical management strategies. Now, what are we talking about? The various options for us are in terms of ejaculate sperm abnormality. How do we deal with it? Surgery to facilitate ART or improving the success rate. The role of biopsy, azoospermia, both obstructive in terms of epidermal or basal, distal ejaculatory obstruction, and then you have your sperm retrieval in terms of azoospermia, both versus obstructive and non-obstructive. I have summarized it this way because this is what normally you see. So I'll go touch upon one by one. Where do we detect ejaculate sperm abnormality? We all know that varicocele, probably which constitutes 35% of subfertile men, is associated with lower sperm count and quality, has a lower sperm functional characteristics with elevated oxidative stress and elevated sperm DNA damage. And consequently, we know that this can be present both in fertile and infertile men. So we know that it can be present in infertile men about 25 to 40% of cases. And the mechanism responsible for infertility in this scenario, how does it reduce the sperm parameters, is because of various theories, but some of the common theories are increased intratesticular temperature, delayed removal of local toxins, or hypoxia and stasis. Though there is no specific causal relationship, these are presumed to be there. And the guidelines, because it is present in both fertile and infertile population, varicocele repair is only indicated to improve semen abnormalities if it is palpable, if partner has a normal fertility, or if they are interested in future fertility preservation. Varicocele repair is also not indicated when you have an atrophic testis, elevated FSH, or severe oligospermia or azoospermia, especially when the concentration are less than 1 million and motility is less than 10%. So these are some of the indications. So the traditional concept of varicocele surgery has always been infertile couples, like I just said, normal female or treatable female infertility, abnormal semen analysis, or a sperm function test. If you have all these criteria met, and I said if the testis is normal and FSH levels are normal, then only you offer varicocele surgery as a means of possible improvement of sperm. Now, so consequent to that, I'm going to do. So when you do varicocele surgery, what are the caveats? One is it should be palpable and at least one abnormal semen parameter. And in this kind of an instance, you have a result which is favorable for surgery. And that is why varicocele surgery is proposed for this specific group of population. Now, where is this surgery done? We know that the idea of varicocele is this mesh of these veins, which are external pudendal veins, are ligated. We all know historically from Paloma's time, which retroperitoneal, inguinal, now is the subinguinal. The idea is to preserve the arterial anatomy and only ligate the venous and also preserve the lymphatic anatomy. So consequently, we knew that because the surgery was done in different places earlier, retroperitoneal, laparoscopy, embolization, inguinal, you had two common things. What are the two common complications? One is the recurrence rate and the post-surgery hydrocele rate. So now we know with the subinguinal, especially the microsurgical, your recurrence rates are very low and hydrocele rate is very low, and it is the preferred approach over embolization, which or laparoscopy, which some people still recommend, which is not ideal for a varicocele surgery. Now, in order to ensure precision, you can also use a microvascular Doppler to identify the artery if you are not using a loop magnification or a microscopic magnification. What is recommended is a magnification. Additionally, some people use a microvascular Doppler to identify the artery. Now, with the Doppler, when you use the number of veins ligated, as you can see without Doppler, with Doppler, definitely increases, and arterial preservation is much more scientific and robust. So this is what is gaining credence nowadays, along with microsurgical varicocele ligation, whether we should be using intraoperative Doppler in order to preserve the arteries without injury, and also number of veins which are ligated and lymphatics which are spared. All this adds to the quality of the surgery and a successful outcome, which is increase in the sperm parameters and possible conception. The other two indications where varicocele surgery is being proposed are, one is we talked about fertility restoration, which is what is in oligoasthenospermia, which is what I just discussed, where you are doing the surgery either to improve the sperm parameters in order to achieve a spontaneous pregnancy or improvement of his chances in an ART, or fertility improvement, especially ART ICSI outcomes and sperm retrieval in azoospermia. These are the two additional indications for varicocele surgery. So new indications of varicocele surgery are for sperm and also for ART improvement. Why do we need this? Because there are additional theories which suggest that metabolite reflects into the testis and increased ROS creates sperm DNA damage and hormonal dysregulation. So repairing varicocele prior to ART improves pregnancy and live birth rates in oligospermic and azoospermic men. Non-obstructive azoospermia, where we know that sperm retrieval itself can be a challenge, shows an increased return of sperm to ejaculate following varicocele repair and higher rates of live births when compared to controls with NOA and no varicocele. So consequently, these are all new indications where people have started repairing gross varicocele, palpable varicocele prior to ART to improve pregnancy rate, or you could even do it if there is a failed IVF cycle, or in non-obstructive azoospermia, which gives increased chance of return of sperm to the ejaculate or chance of finding intratesticular sperm. The third indication is there have been several published studies, especially by Ghani et al., which shows in a randomized controlled trial, varicocele repair in couples with recurrent first trimester miscarriages may be useful. So these are additional indications. They showed that varicocelectomy significantly improved semen parameters, intrinsically also pregnancy rates and decreased miscarriage rates. So consequently, when you look at treated varicocele and untreated varicocele, especially before an ART like a Micc, you see there is an improved fertilization rate, live birth rate, and reduced miscarriage rate in men pre-treated with varicocele surgery before an ICSI. Similarly, varicocele repair in azoospermia, especially if you look at histology of where you have done, if you have this report available, hypospermatogenesis, maturation arrest, Sertoli cell only syndrome, you know that there is an improvement in the sperm retrieval or even ejaculate sperm. And there have been reports of a spontaneous pregnancy also, but you should look at the mean follow-up time of approximately a year or a year and a half. So this counseling is very important, especially if you're doing varicocele repair in an azoospermia. That means the patient has to wait for a year, year and a half for improvement in the sperm parameters. And you can see motile sperm also comes in 35% of instances in these men, provided they are willing to wait. So sperm retrieval in men and intracytoplasmic sperm injection with non-obstructive azoospermia. That means where we have treated varicocele and untreated varicocele, intratesticular sperm retrieval is likely to be more successful. Even if ejaculate sperm doesn't come in an individual, it is likely to be more successful if you have treated the varicocele prior to the procedure. So you almost have a doubling of the sperm retrieval rate, especially if you have treated the varicocele. So that is to summarize the various indications of varicocele, which initially started as a treatment only for oligoastenospermia. Now we believe, because of the complex hypothesis of toxic metabolites and also hormonal dysregulation, whether varicocele surgery should be offered to other groups of individuals who have challenging fertilization rates and also lower pregnancy rates because of either recurrent abortion or non-obstructive azoospermia, and so on and so forth. The other surgeries which are commonly used are surgery for obstructive azoospermia. Where all obstruction can happen, it can happen in the epidermis, vas deferens, or ejaculatory duct. These are the three common sites of obstruction. Surgical management of azoospermia evolved with identification of vas and identifying the site of obstruction. So vasography was the first evolution where people attempted both antegrade and retrograde vasography. Retrograde vasography required a little bit of skill, bulb tip catheter, and preferably that was done by a urologist, whereas vasography, which was more easier to perform because vasectomy was performed by most of the surgeons, and they could identify the vas and perform antegrade vasography, which will give a complete comprehensive information of distal reproductive tract, which facilitated a proper management strategy. So the other indication, once you have a vasography, distally the vas is normal, then you have to look for causes. What are the causes? It could be an obstruction because of a previous vasectomy, then you opt for a vasectomy reversal. But we have to bear in mind that long-term vasectomy, because of back pressure, can cause epididymal obstruction. So the classic way is to identify sperm in the proximal cut tubule of the vas. If sperm is present, then you know there is patency. Then only you do a vasovasostomy. Otherwise, you have to do a vasoepididymostomy. And this was the evolution of the vas clamp, which held two ends of the vas together so that the retraction of the vas, which is a dreaded problem, doesn't happen. And you could use this clamp and bring the vas ends together for an anastomosis. The classical way was a single layer anastomosis, which was initially practiced because of granuloma formation. Initially 4-stitch, then evolution of 6-stitch, then 8-stitch vasostomy came into picture using an 8-0 or a 10-0 proline. It was a mucosa to serosa anastomosis. Now we believe because of granuloma formation and some leak of the vasal fluid, a 2-layer vasovasostomy is more robust. So you have a primary layer, which is of the lumen mucosa with a little bit of serosa, and then you have the serosal approximation which is usually in the form of 8-stitch vasovasostomy, which is practiced now more commonly. And when you look at microscopic vasovasostomy versus microscopic vasovasostomy, because vasovasostomy is practiced by a lot of people macroscopically without a microscope, you see the patency rate and pregnancy rates of a macroscopic versus microscopic is almost double. So consequently, microscopic vasovasostomy is the gold standard, and a 2-layer vasovasostomy is not what is practiced. And there are several studies to confirm that 2-layer is very good. There are some people, only Belker, who did a single layer and had good results, but generally 2-layer seems to be the way to go forward. Now, what are the prognostic factors for a vasostomy or a vasoepididymostomy? What tells you that this anastomosis is likely to work is obstruction interval, presence of granuloma or hydrocele. If you have a granuloma at that site, or if there is a hydrocele, obstruction interval is prolonged of more than 10 years, then they are all negative factors which might tell you that the prognosis is not going to be as good as the normal de novo case. Surgeon experience, fluid aspect macro, where you find sperm, fluid assessment for sperm, presence of sperm, all are important. Fluid aspect in the sense if you find a lot of pinheads, or if the sperm fluid is very thick, inspissated, then those are not good signs, which gives you a favorable prognosis. Now, microsurgical vasovasostomy in different series has different pregnancy rate, but average pregnancy rate can vary depending on the expertise of the surgeon, from a 30% pregnancy rate and a patency rate of 70% to 97%. 97% is rather surprising, because in India, we find many a times we open up for a vasoepididymostomy and the epididymis may not be dilated. So there are challenges. So I would ask people to tread with caution, especially because vasoepididymostomy is a complex procedure, requires a lot of surgical expertise, and should be done with a microscope in experienced hands. But overall pregnancy rates matches an IVF or an ICSI pregnancy rate, and that's why there is an interest in performing this surgery, especially considering the socioeconomic status of the individual, and also considering there's no cost for a pregnancy subsequently if the couple so desire. So vasoepididymostomy initially evolved as an end-to-end, then evolved as an end-to-side, then it became as, just like a vasostomy, 8-stitch. Then we know now we do 2-stitch, 3-stitch invagination, vasoepididymostomy. Earlier, the concept was to mobilize the vas completely. Nowadays, we don't mobilize the vas completely because we believe that it may injure the arterial segment. So we do not mobilize the vas. Now it is always end-to-side vasoepididymostomy which we perform, and it could be a crossover, because if there is a vas which is damaged on one side, you can bring the other side vas and perform the crossover vasoepididymostomy. So these are the various vasoepididymostomy techniques: terminolateral, triangulation, modified triangulation, intersection 2 suture, intersection 3 sutures, with approximately similar. Only reason why people are preferring intersection 2 suture and 3 suture is the ease of performing a vasoepididymostomy, which has become less complex as we have evolved. So vasectomy interval and obstruction at the level of epididymis, we know that if the duration is less than 3 years, then the chances of epididymal obstruction is less. As the duration increases, the chance of epididymal obstruction increases, and pregnancy rate also drops, as you can see. That is why it is very important, one, to demonstrate sperm at the proximal end or go higher up if you don't find the sperm. Always bear in mind, it may be an epididymal obstruction what starts off. So this is at the level of epididymis. I have described the vas difference. Now, ejaculatory duct. There are 2 types of ejaculatory duct obstruction. One is the congenital, which is the prostatic cyst or ejaculatory duct cyst. Generally, they do not cause obstructions, very rarely unless they are very big. And the diameter of the ejaculatory duct should be more than 1.5 centimeters to consider it an obstruction. Many times the sonologists report obstruction, which may not be obstruction. The clinical features are hypospermia, where the volume is less than 1.5 and acidic semen. Iatrogenic is, of course, acquired is iatrogenic or post-infectious ejaculatory duct obstruction. Here again, we do a vasography, which is antegrade, demonstrate there is an obstruction, because many a times it could be fibrosis not amenable to ejaculatory duct obstruction, which is the congenital variety. As you can see, there is a thin streak of contrast which is coming. It is never completely obstructed. So, and then with a TUR loop, this is the verumontanum. You identify the veru, ejaculatory ducts come over there. You can inject methylene blue so that you can get transparency or visual field. This is the methylene blue injectant, and resect so that you don't damage the internal sphincter. Now, semen quality improvement, especially in acquired, is very low. Only in congenital, you seem to see a good improvement in semen quality improvement and also a good pregnancy rate. In the acquired variety, surprisingly, for various reasons, pregnancy rate is very low and semen quality improvement is very low. So there is a debate whether we will really be doing acquired ejaculatory duct obstruction surgery, because they may be better off with an ART procedure. As I just showed you, this is the acquired, which is the iatrogenic and post-infectious. So that is where we are, to summarize. Last is the sperm retrieval techniques for ART. Now we have two types of procedures here. One is the obstructive and the non-obstructive. So obstructive, we all know that is normal sperm production, possibly a mechanical blockage, either because of vasectomy, post-infectious or congenital. Non-obstructive, we know is sperm production deficient or absent, and various causes for non-obstructive azoospermia. Obstructive azoospermia is an idiot-proof game. There are various procedures which have evolved over the surgery, generally putting in a needle either in the epidermis or in the testis, which are PISA and TISA. There was a concept that if you accumulate a lot of sperm, microepididymal sperm aspiration, you could possibly do IUI. That's why there was an evolution of MISA, which is a given up procedure now. Nobody knows, it's only of a historical interest because there is no need to expose the epidermis to retrieve the sperm. So PISA, again, you fix the epidermis, and I will show you a couple of videos for the same. And TISA, you fix the testis. Is there a difference between a PISA and a TISA? There is absolutely no difference. And the sperm retrieval rate in a PISA or a TISA is approximately, in CBAVD, depending on the etiology, it is 100%. In a vasectomy, it is 96%. After infection, it is 96%. So literally, you almost get sperm in any of these situations. Now, the second question is, when you have retrieved the sperm, is it as good as an ejaculatory sperm? Especially, is there going to be any defect in this sperm which prevents fertilization? As you can see, people have looked at the pronuclear formation, pregnancy rate, miscarriage rate, live birth rate. They are all uniformly similar. There is no difference between an ejaculate sperm and a sperm retrieved from the epididymis or the testis, irrespective of the etiology, in terms of health of the baby, in terms of embryo formation ability. So this is what it is. So I'll just show you a brief video. I'll just finish in the next 5 minutes. So this is PISA and TISA. So of course you can have all these laboratory procedures. So this is where you fix the epididymis. Of course you inject local, so that you inject to the vas, basically because the vas contains the nerves to the testis, and then you directly puncture the epididymis and aspirate with a little bit of media. So it's a very simple procedure. I'm just going to rush through. So I'll just show you in this part where we are fixing the epididymis. So you fix the epididymis so that it becomes taut, and it sort of this one. So that is the way you can use a tuberculin insulin syringe or whatever syringe you're familiar with, and just directly plunge the syringe in one plane. Don't make multiple entries, and just aspirate the fluid. And once you aspirate the fluid, your embryologist or your andrology technician can check for sperm and make sure that there is sperm present in that fluid, and then they can use that for freezing or an immediate procedure if it is so desired. So we also sometimes use a butterfly, which is a 24 gauge butterfly. You can use a 24 gauge or a 22 is too thick. So sometimes we have used a 26 gauge butterfly. And so either a direct insulin syringe approach, or this is for a testicular step. Here I have fixed the testis, and with one puncture I'm entering into multiple planes. Generally the planes you enter are 3, 6, 9 and 12, and there is a rotational effect because you have to share the tissue. It's something like a morcellation which you do, and then there are two types of techniques where people clamp the catheter and then pull out, or there is a suction maintained at the end of the syringe constantly, and then you push the tissue out. So that is the way you can do this procedure. So both are, it depends on the comfort level you have and whatever you feel is nice. I don't use a clamp technique. I use a suction technique, and the clamp technique is generally, sometimes the tissue may not come out very well. And of course, there is also this procedure, as the tissue is coming out, you can pull out more tissue from that solitary tubule as it is coming out. So consequently, these are variations in the procedure which you can adapt. And so this is like I said, obstructive azoospermia is an idiot-proof procedure. So the challenge is non-obstructive azoospermia, because here earlier it was thought that it was an untreatable condition, and consequently very few people had an idea how to retrieve sperm. And what are the challenges? The challenge is only not in obstructive azoospermia, where there's a full epidermis, normal testis, or in a primary testicular failure, where nowadays we don't call it primary testicular failure because it means a negative connotation saying no sperm. We call it dysgenetic testis because it does not mean that there is no sperm. It is dysgenetic, where the production is abnormal, but you may still find sperm. So these two are classical entities which can be easily diagnosed. The challenge is where you are not sure whether the testis size is normal or the epidermis is full. So this is the challenge. So what are the tools you have? You have only a clinical examination and an FSH. So consequently here, there may be a need for a testicular biopsy for differential diagnosis. Otherwise, there is no need for a testicular biopsy. And if at all you are doing a testicular biopsy, especially in a center where there is no cryofreezing facility, you are expected to do bilateral, multiple, at least 4-quadrant microbiopsies. The idea is, if it is normal, you can recommend for an VE or an ICSI or freezing. If there is no sperm at 4-quadrant, then you know that the chance of finding sperm in that given individual is only with a micro-TSA. So you can expect to counsel the patient of the cost implication of a micro-TSA and an ICSI. And if he doesn't want to go through that way, then he can go for a donor insemination and an adoption. Similarly, if there is focal sperm present, again you need to counsel him of the TSA ICSI, because of course you would have counseled this right in the beginning. So the question there is, either you freeze this sperm and use it, or you do a fresh case biopsy at the time of ICSI. Generally nowadays the freezing of the sperm technology is very good. There's no need for a repeat biopsy at the time of the ICSI. So that is an indication of biopsy, only one specific indication. And biopsy results of earlier days, which people used to report hypospermatogenesis, maturation arrest, Sertoli cell-only syndrome, normal spermatogenesis, except for normal, does not have any meaning, because all these are dysgenetic testes and they can have sperm production irrespective of the nomenclature. So this is what it is. Testicular failure term no longer used. It is dysgenetic testis, does not mean no sperm. It means it could be no sperm. Then you classify as primary testicular failure, or it could be a few sperm, patchy spermatogenesis, or many sperm. So in non-obstructive azoospermia, you had the simple TSA, or taking out a little bit of tissue and examining, or a microtesticular sperm extraction. So why is this, all these challenges in a non-obstructive azoospermia? Because the goal is to identify site of production and retrieve sperm for ICSI. The geographic location of site of production can be very difficult in a non-obstructive azoospermia. So consequently, people are trying to see whether we can predict which testis will have sperm. Because the question is, there are only 600 to 800 seminiferous tubules, and a single focus of production is adequate to retrieve sperm for ICSI. So consequently, can we have predictors? The predictors used are FSH, NEBINB, testicular volume, etiology, testosterone levels, testis histology. None of them are the accurate predictors of spermatogenesis. They can predict the most advanced site of sperm production, but not the best, with a guarantee, none of the markers can predict individually whether there is sperm production. Of course, now we have evolved microRNA gene studies, which seems to be a better predictor with 95% predictability. I have not put that in this slide presentation, but that is the way people are going about it. So consequently, people relied on histology. Histology, we know hypospermatosis means nothing. You could have a 93% sperm production, heterogeneous inside the testis, in maturation area 60%, in Sertoli cell 20%. So consequently, and the second question was, if we retrieve sperm in this kind of individuals, would it affect the baby? Now, when you look at sperm retrieval, 2PN fertilization versus non-obstructive and obstructive, definitely the chances are lesser. There's a lesser fertilization rate, but there is still a 20% live birth rate and a healthy baby rate. So consequently, though it is not as good as an obstructive azoospermia, still a lot of men who want their own biological child should go in for their non-obstructive azoospermia. This is my last 1 or 2 slides while I'll show you. And this is the needle aspiration biopsy, where when I said you can do 4-quadrant or 6-quadrant biopsy for people who are not financially well-to-do, just to know what are the chances of finding the sperm. So we recommend nowadays what is called as a stepwise procedure. A stepwise procedure is you do a 4 or a 6-quadrant biopsy. That means it is called as a single seminiferous tubule biopsy, where you aspirate tissue by rotating one butterfly, which is usually we use an 18-gauge butterfly. So you use that and take out the tissue and examine. If there is no sperm in 4 or 6 quadrants, the chances of finding sperm in that given individual is only 25%. So consequently, many people may opt for a donor insemination if they are not financially well off, because 75% chance he may lose the micro-TCA surgical cost. So consequently, so this is the clamping technique which I was just describing, where you clamp the tubing to generate negative pressure, and as the needle is withdrawn, you will find the tissue coming out and you just pull the tissue. So that is the clamping technique which we recommend, and that is what is used to aspirate the sperm. So the next procedure is this, where if you don't find sperm and you still want to go ahead with the next step, I'm showing you this, where I've showed you microsurgical versus non-microsurgical microtesticular sperm extraction. So here we are doing, this is an old redo microtesticular extraction. That's why you see a scar there, longitudinal. There are people who use a longitudinal incision. I prefer a longitudinal, but a lot of people use a horizontal incision because they believe that the blood supply is from lateral to medial. So this is the way you will see the testicular tissue. You invert the whole tissue. You will see the testicular tissue. I'm sure you can't make out the tubules in this tissue. And this is the way you will see the tissue in a macroscopic environment. And if you have to pull out a sperm producing area, then you need this magnification. This is the 20x magnification, where you see if you magnify, then you are seeing precisely the tubule. So we are going to switch back and forth just to show you how crude it is to do it without magnification. So here is the area where there are few tubules which seem to be dilated, and you just pick up those tubules and send it to your lab just to make sure whether there is any sperm. So this is a precise way of identifying few tubules which are dilated and targeting only those tubules which you want to select and sending it for processing in the lab. The same one, if I had to do it without microscope, I would be pulling out chunks of tissue like this and sending it to the lab, which is irrational, where we don't know what we have picked up. It is just a random biopsy sort of a thing. Only thing is, this is after exposing the testis. So one of the challenges in a micro-TCA is, where is the sperm present? Usually in the peripheral areas. These are the areas where you have very little exposure. So that is the area which people are concentrating now in terms of sperm retrieval. So sperm retrieval, central areas are usually more visible. So the peripheral areas you go, that is where you have to ensure that you are very precise. So as you can see, this is the area where there is a few creamy tubules, whitish tubules which are dilated, and you just pick up those tubules and send it for testing of precisely those limited number of tubules which you are going to send it for testing. So, so this is a much more precise way of doing the procedure. So in summary, I would like to summarize that there are various surgical procedures which have evolved over a period of time. Varicocele, sorry for that typo, varicocele repair was the first surgery which was performed for oligoasthenospermia. And now there is a refinement that it should be subinguinal microsurgical technique. And also there is a further refinement where all indications we need to do, where we could do varicocele surgery. Similarly, vasovasostomy and vasoepididymostomy have got refined over a period of time. What is the type of incision, whom to do, where to do, what is the expected results, how long to wait, all these are getting refined. Similarly, transurethral resection of ejaculatory duct, we know precisely whom to operate, and sperm retrieval technique have found new indications, and also precisely who we should offer and how do we go about counseling. The only challenge is still a gray area is in non-obstructive vasospasmia, how do we counsel an individual? What are his chances of finding the sperm? So with this, I would like to thank Isar and Kedar for this opportunity. And thank you very much, ladies and gentlemen.
Thank you, Vasan. Without wasting much time, we will go to the question answer. The first question is for Dr. Kishore. Is there any other method of semen collection apart from the cup, as many times people don't feel comfortable in collecting in the cups? Kishore? Okay, Kishore is not there. Okay, maybe we should go to the next question.
He's there, he's muted, he just came back. Yeah.
Hello, can you hear me?
Yeah.
Yeah. See, there are different ways of collecting the semen. One of them, the most commonly used method is the wide mouth container. And a good proper boys' room, what we call a proper sitting arrangement, washing arrangement, where undisturbed masturbation can be done. The other way is, of course, to use a condom, a silastic condom, and ask the patient to have intercourse with his wife, and then collect the semen from whatever inside the silastic condom. Not a condom, but a silastic receptacle. The third method is, of course, using a vibrator, and he will ejaculate spontaneously. And electro ejaculation, of course, it is very good, electro ejaculation, but it is not done routinely. It is done for paraplegics and people who are unable to give by you.
My question to you is, in a varicocele patient, when you examine the patient, one should examine the patient lying down or in standing position?
You're asking me?
No, Kishore.
Yeah, I examine the patient in standing position. All inguinal-scrotal swellings are examined in standing position.
And the Doppler ultrasound, which is to be done, which is done usually lying down.
Yes.
Should it be done in a standing position?
Sometimes if I can't elicit a proper reflux, I do it, but usually we do it in a lying down position only. Okay. We can get the reflux very clearly in the lying down position also.
Okay.
I do it myself.
Okay. You said something about live tissue biopsy.
Yeah, that's what Dr. Vasan showed now.
Same. Is it TISA?
Putting a needle and taking it, trying to retrieve the sperms, whatever sperms come, and the remaining tissue, whatever little you have got, you can send it in Bowen's fluid
to histopath
or buffered glutaraldehyde solution. Usually formalin is avoided, formaldehyde is avoided, and you can send it to the histopathology and they would.
Okay. But is there a role of testosterone cream in the management, and what are the contraindications for testosterone replacement?
Testosterone
cream in the management.
Yeah, there are different ways of administration of testosterone. Cream is also available. Oral tablets are the most preferred. You can get injectables, which are intramuscular injections, as well as depot preparations. And you can get nasal sprays as well as gels, the cream that you're talking about. Androtas gel, Cernos gel, gels are available. So 50 milligrams per day is the dose. And this can be given to people, but generally in the reproductive age group, we are very cautious with testosterone. because it can suppress FSH and reduce spermatogenesis. So the indications for testosterone are usually testosterone deficiency states, that is andropause, where not for infertility, and hypogonadotropic hypogonadism, you can give testosterone because whatever testosterone you give to hypo, they will absorb it. They will take it as much as possible. So I prefer tablets to cream, but when tablets were not available in between for 6 or 8 months, tablets were not available. At that time, gel was I was using gels, the containers, 4 puffs at a time. 60 puffs is in one container. So that lasts for 15 days. 4 puffs per day means 4 presses per day for 15 days. That would cost around 1,500 rupees.
Okay. This is a very common thing. Many patients use supplements and injection for bodybuilding in gymnasium. So which are these supplements? I think both of you can add a little bit on this point for having an impact on infertility significantly. Which of the supplements can have impacts?
Androgenic anabolic steroids, that's the common name for that. I think they are testosterone derivatives. They're anabolic steroids. Nalodrone is the one that is commonly used by sports medicine people. And I don't know the other compounds that are used, but many of these powders which are used for protein supplementation are worse laced with now awareness has increased now. They were laced with androgenic anabolic steroids. And of course, these are dangerous because they would suppress the axis and they would reduce spermatogenesis. And that is why you have to be careful. Vasan, do you know of the other chemicals?
I think what you said is correct. I think that is, most of them are anabolic steroids, and consequently, there are various varieties of anabolic steroids which are used by people. And so basically, just to help in increasing the peripheral testosterone. They are more concerned of increasing peripheral testosterone.
Okay. Both of you, is there a role of correlating inhibin B as a marker of Sertoli cell function for predicting the getting a sperms in TISA?
Yeah, we have done I did a major study on this. We selected more than 200 patients where we did between the inhibin B. This will do inhibin B. It's a poor marker. First of all, when the levels are very high, then it's a good marker. And if the levels are very low, then again it's a good marker. When I mean levels are very low, levels below 20 to 30 and the levels above 100. The problem is 30 to 100 is the one where you will have a challenge. Between 30 to 100, we try to correlate it with an FSH. If FSH is high in this group, despite having 30 to 100, we warn of a poorer prognosis. If FSH is normal and testicular volume is normal, then the prognosis may be better for this group. So as far as I'm concerned, isolated inhibin B as a marker is a poor marker. But with testicular volume of more than 12.5, as well as an FSH which is less than 7.6 and an inhibin which is normal, whatever is the lab range, 60 and above, is for many labs reported that way, then the predictability becomes 90%, not 100%.
There are some patients who come to us with a count of 1 million and the FSH reports is absolutely normal. How can we explain this now?
There is what is called as receptor unresponsiveness.
Okay.
At the end of the day, there are individuals. That's why I said there are what we have. In fact, I have a presentation where we discussed this. That's why you have this pale A spermatogonia, pale B spermatogonia, FSH receptor type A, receptor type B. And so at the level, you can have a receptor blockade, receptor apoptosis, which the brain doesn't sense. So not necessarily brain will sense all abnormalities. So if it doesn't sense, then it is not going to put in more FSH just to overcome the problem. So many of these receptor abnormalities are not sensed by the brain. Brain goes by the hormonal milieu and then understands whether there is an abnormality or not. So consequently, a normal FSH and a dysfunctional testis is quite common.
In
The
this,
low counts, if the counts are transiently low, for example, in subclinical viral infections for
no,
or
Kishore,
say
no,
in
Kishore,
COVID now.
no, Kishore. I'm talking about consistently coming low. So in this situation, is it worth giving anti-estrogenic therapy or giving letrozole or HMG or SCG? It is going to work because the receptor blockage is somewhere low down.
Yes.
And so it's not going to work. We have to take them for ICSI as early as possible.
Absolutely. What you say is right. In fact, we have an algorithm for that where I've built. The only indication in this case is a very low dose steroid. We use the steroid for about 3-4 weeks because you can't alter spermatogenesis. You are going to alter only spermiogenesis. And if your motility improves or some amount of, so what we believe is spermiogenesis, now we know that it's a 14-day event or an 18-day event. So you can modify it and I use a steroid dosage of 2.5 milligram twice a day for about
Vicelon.
And use it for about 3 to 4 weeks. Repeat a sperm test. If there is no improvement in the semen parameters, that individual is unlikely to. So there is no point in wasting time.
Okay. And as far as the antioxidants are concerned, that also doesn't seem to going to be work for this.
At the end of the day, if you demonstrate, see, you have to be very clear. Just like antioxidants are not miracle medication.
Absolutely.
They are not. They are meant to facilitate a better fertilization in those where there is a protomination deficiency or one of those challenges, lipid peroxidation challenges. All of this will manifest as some form of either oxidative stress, which you can measure with ROS, or DNA fragmentation. And my basic presumption is if you're going to put up subject a person for an ART, you might as well do a DNA fragmentation. If his DNA is normal, and then the role of antioxidant in that kind of an individual doesn't make sense at all. So only if it is abnormal, you give. It is not meant to be given to normalize a sperm count in oligoasthenoteratospermia, which is what is happening nowadays. Because at the end of the day, oligoasthenoteratospermia is a Sertoli cell dysfunction and a Leydig cell dysfunction. So that there the medication is at best empirical, like Kishore just now mentioned. Either you activate the Sertoli cell axis, or you activate the Leydig cell axis, or you block the intratesticular pathway of testosterone to estradiol conversion. So there you go by your FSH numbers, LH numbers, and TE ratio. So if you activate this axis, additionally, many a times as a co-prescription, as a supplement, you add an antioxidant just for whatever benefit it gives you. But actually, it should be added to those who have a DNA fragmentation deficiency.
So what you are saying is do a DNA fragmentation. If the DNA fragmentation comes high, about 30, then the role of antioxidant would come
even for that matter, if you're doing 15 to 30, I would still put them on for whatever benefit it would give them. But below 15, it doesn't make sense.
But then with the now Kishore or both of you can give. Now with the microfluidics and all those things coming in, whereby we can select a less DNA fragmented sperm anyway for ICSI, is it worth treating this patient with antioxidants?
Now, my presumption is if you're looking at an ART procedure, optimizing sperm in all methods is not going to be harmful to you. And these are not very expensive. The challenge is how long and what duration. I believe that one spermatogenic cycle is good enough, and also here you are altering spermiogenesis parameters. You are not altering spermatogenic parameters. Nobody can change, spermatogenesis in any given individual because it's prefixed just like your ovarian, follicle recruitment and other things. You can change that dynamically. So if you are altering spermiogenesis, you are looking at altering a 21-day event or a 14-day event. So 1 to 1.5 months would give you sufficient lead to normalize his sperm parameters, which is the normal time you would take to get the woman ready from her cycle point of view and other things. So it facilitates a better sperm on that day and you don't have surprises. But still, yes, you are right that if I have not given this, would it be detrimental to the patient? I don't think so. Because now, if you're using those technologies which you just mentioned, which are pretty good nowadays in identifying the right sperm, so it should not make a difference. So these are, I would say, complementary in nature, but not, directly.
I'll ask this question. Great grandfather, okay, great grandfather married early, high testosterone, high estrogen, okay, sex almost every day or twice a day, okay, right? And now today we have double income, no sex group category, okay. Do you think by increasing the frequency of intercourse or ejaculation per se, okay, this audience gathering should know, will it improve the results of the ART procedure? B, does it change the spermiogenesis or that the window? See, now for female it's different. For men, you keep ejaculating, you will require the new demand. I've just, out of the box, I'm thinking now. So a man who was, say, start ejaculating 3 times in a day, okay. So the spermatogenetic process can be shortened. Can it be shortened?
No, it cannot be shortened because spermatogenic cycle is a 56-day cycle now because of some radiotechnic studies and all that.
But not 74 days now. It's 56.
56, yeah. That's
okay.
Right.
Okay.
So what I'm saying is now we know that during COVID, you read a lot of reports where people naturally conceived because they were more intimate and probably had more sex during that period. So to answer your question, yes, does spermatogenesis improve with more sexual activity, more frequency? Yes. See, it's like, you can as well know that when your desire is more, your ejaculate volume suddenly improves.
Absolutely.
You ejaculate more. And suddenly you feel, where is this volume coming from? I didn't have this like this. So these are all natural. I mean, I think one of the fundamental aspects of human being is the more positive you are, it impacts your body more. That's why you have yoga, and I'm sure Kishore will answer this much better than me, where you have all these supplementary therapies which have all helped the individuals, So my take is yes, definitely yes. What you said is if they're more intimate, it will help.
Now, but both of you can answer this. Huh? This is like we see a lot of patients coming with decreased ovarian reserves, okay, and you see a lot of imbalance between sympathetic and parasympathetic nerve system, right? Now we are exposed to a lot of sympathetic stimulation. For every now and then, we miss a train, we are stressed. We are going to meet a boss, we are stressed. So micro stress, we call cortisols are being released, okay? And obviously in the night, the bheja is fried, so there is no sex happening, nothing is happening. So tell me, will this stressful hormone, in your review of literature, have you found, is it showing any improvement, any detrimental factor? Because it's all coming because of the technology, right? It's all coming because of the technology. You see the number of patients coming to us today are belonging to the category of 30 and above, okay? And they married for 5 years and tried for 6 months, and they're now running about helter-skelter, okay? So men are also suffers because of this. I'm not saying no. But then how do you, now, do you think this can, like in women, we say doing yoga would help because she's going to carry the pregnancy. Obviously, the man who's going to give the pregnancy, we never tell a man to do yoga. We just tell him to stop drinking coffee and smoking and alcohol, right? And maybe to reduce weight. So do you think what I'm trying to make sense is improving the parasympathetic stimulation, is it going to help you test spermatogenesis or spermiogenesis?
And I think overall lifestyle improvement is very important. It is proven now that stress in all forms through cortisol secretion, through secretion of catabolic hormones, definitely affects spermatogenesis. But I don't think it is specifically related to the sympathetic or parasympathetic system as such.
Okay.
It is more of a lifestyle problem. You need to regulate your life properly. You need to have adequate sleep, reduce your stress levels. Weight reduction, I have found, is extremely important. 5% reduction in weight has produces 5 to 10% improvement in sperm parameters. We have in Surat, for example, we have lots of patients who are 150, 140, 120. You get at the time when they come, and it's so difficult. And many of them, we subject them to bariatric surgery. Even the bariatric surgery, post-bariatric surgery, also their sperm parameters have improved.
Oh, wow.
So I think stress it's not just stress. I think it's lifestyle, stress, alcohol, drugs, tobacco, adequate sleep. All those things are important. That's what I think. And about sex, you were telling the other time, the ejaculatory volume is actually constituted largely by the prostatic and the seminiferous tubule secretions. And as the age advances, the total volume of semen decreases, partly due to it is all, I think, DHT regulated. And many times in sexology, when people with sexual dysfunctions come to me with a very low volume or not able to lubricate properly, not getting enough volume, you have to actually make them think right, make them have sort of, when you are in a more sexy mood, when you are horny, when you are seeing porn, when you are doing foreplay, or that's the basis of sensate focus also, that you do it in such a way that that everything becomes wet, and the volume definitely increases. So you do just sex like that, just masturbate just like that, and you masturbate with add-ons, and after proper stimulation, visual, whatever, sensate, the volume of semen definitely increases, and it can increase to 2 times, 3 times. I have seen a 0.5 ml semen can become 2.5 or 3 ml also. So I think it's largely related to the thinking and subclinical mental state, which in turn is related to the hormones.
What you say is, Kishore, is correct. In IVF laboratories and for semen analysis, on an average volume which is given is 0.5 to 1 ml.
Correct.
Okay, average I'm talking about, average I'm talking about. Okay, now Vasan,
Yeah.
there is a patient with cryptorchism surgically treated at the age of 12. So they got the testes down. Will the evaluation algorithm be the same as a normal person, or some other tests are required?
No, only thing is in a cryptorchism testis, you are always worried if it has been brought down. Also, you are worried about whether there is a transformation of this testis into some form of malignancy, because there you don't know whether there is a slightly higher chance of a cryptorchid testis. Once it is brought down to the environment, so the chance decreases, but still there is a slightly higher chance. So the only thing we do is an abdominal ultrasound just to make sure there are no lymph nodes, because you can't palpate them. So consequently, other than that, the algorithm remains the same. In fact, the retrieval of sperm, surprisingly, in a micro surgically operated or operated cryptorchid testis, seems to be higher than any other testis. So in fact, of course, you can't get normal ejaculate sperm in these individuals. Very rare for a cryptorchid testis which has been brought down to have normal ejaculate sperm if it is bilateral. But the chances from retrieval seems to be very good. And the algorithm remains the same.
What is your take on these techniques called scrotal cooling pads and scrotal cooling? You open up YouTube and you find all these.
I'm yet to see a patient who can wear it and walk around.
I wonder. And which is the empirical antibiotics you would give in a patient of Asthenospermia? Now, nowadays, what is happening, what I'm seeing in Bombay, is the count is about, say, 8, 10, 12 million. A grade 0. B grade 30, 20, 30, 20. Now, man is normal, glucose is normal, when there is no varicocele. FSH normal. How do you treat it?
Yeah, I have a very interesting.
So I think
Go ahead.
all the things that I mentioned, lifestyle modification, antioxidants, you have to go according one by one and treat it.
Okay. So basically what you're saying is treat the, if at all there is, do you always do semen culture?
We do semen cultures. I actually had learned it the hard way. We had patients from Pune coming, many of them techies and all that, the double income, no kids wale. So many times when I empirically wrote antibiotics, I used to write doxycycline. Nowadays, I've started writing azithromycin, 500 milligrams. So when I used to write the antibiotics empirically, they used to ask me that you are giving antibiotics without doing semen culture. So I thought, why not do the semen culture? So I started doing the semen cultures because this is a lot of people on the net and all they read and they come, and it's for your own protection also. Tomorrow somebody might question you the evidence that you have for giving this antibiotic, particularly if they have some side effects.
No, the culture reports generally. Vasim, go ahead.
No, I strongly believe, first of all, semen has bacteriostatic properties. So consequently, unless you are able to do aerobic and anaerobic cultures, your semen cultures come only positive in about 20% of individuals. And world over, it is known that genital tract infection, especially seminal infection, is to be treated empirically depending on the number of pus cells you have. And of course, you can have both symptomatic and asymptomatic individuals where you go ahead and treat those individuals. If it is most of the individuals you see are asymptomatic. So a course of antibiotics is very well justified, and I don't think it is a medical legal complication because there are enough evidence to suggest that is the way. In fact, guidelines have been written. That is the way to go about it.
So, what is your preferred antibiotics?
I would prefer levofloxacin.
500 BD?
Yeah, 500 OD.
There is no role of giving metronidazole. There is no anaerobic organism affecting the spermatogenesis.
At the end of the day, we presume the chances are less because you require some form of contamination for the anaerobic organism to enter, preferably some form of fecal contamination. So consequently, unless trapezial skin is very dirty and you have examined him, and those are the individuals where, but somehow surprisingly, we find that many patients respond to levofloxacin much better than any other drugs which we have used.
Now let's understand. A man is normal, but he's little abnormal here. Okay, in the mind. Okay. Now testosterone is normal. You see him; he's got a beard and all, and he says there is a difficulty in sex. Okay. Maybe it's not a partner related. It's something else. Okay. So in this situation, do we always treat with the usual line of drug like these tadalafil or are there any other these Ayurvedic drugs which have the nowadays come and musli this thing and that thing and Aeroflow and what not they come and tell me. So what is this? And this astaxanthin is what new antioxidant they've come out with? These 40 times stronger than estrogen. But I said, where is the evidence?
No, there is no such.
There is no evidence, but every combination has astaxanthin. Every combination has astaxanthin.
I think it's all marketing. And as far as those Ayurvedic drugs are concerned, they all come under the broad heading of aphrodisiacs. So there are lots of combinations available.
Which is your favorite one?
Nano-Leo, for example, Nano-Leo sachets are available. Ginkgo biloba, Mucia pruriens, Safed Musli. These combinations, V2, there is something called VTWO.
If I may answer scientifically, what you are looking is in these kind of individuals where there are two types of individuals you will see. Unmarried who have erectile dysfunction on the basis of presumed masturbatory incompetence because they ejaculate too soon or they lose their erection. Married erectile dysfunction. So we have brought out a very simple algorithm for that. What you require in the younger individual is 5 milligram tadalafil straight away because you are expecting him to get an erection which lasts either 2.5 or 5 milligram, which lasts at least for about 24 hours because the half-life of tadalafil is more than 24 hours. And then if he responds to 4 tablets, within 4 tablets, then you ask him to take it once or twice a week and leave him alone. You does not require. And only in younger individuals, you always do a lipid profile because nowadays we find a lot of dyslipidemia, which can cause some amount of endothelial dysfunction. The other group is one with ED with erectile dysfunction, with comorbidity, without comorbidity. Now, de novo erectile dysfunction without comorbidity is going to be happening more in people who have stress, or because of marital discord, or because of lack of desire. And those are the individuals which is a functional or combination of psychogenic with organic. The other group, which is because of diabetes, hypertension, dyslipidemia, metabolic syndrome, obesity, is usually endothelial dysfunction. Now, endothelial dysfunction can be demonstrated. There are various equipment which are coming to the market. Those are the ones you should try along with your tadalafil, because they have low nitric oxide reserves in the endothelium. And there you should try L-arginine or any of these which are facilitatory for their erection. Many of them are happy using those kind of medications because along with L-arginine, it probably facilitates a better normalization of their nitric oxide level and the tissue responsiveness for your tadalafil, which is the PDE5 pathway. So that is where the indication comes in. So comorbid patient, along with usually controlled comorbid is what we want to see, because uncontrolled you will have to bring them for control. There, along with the PDE5, there is definitely a role for these kind of medications, which is what is coming up in a big way. But the research has focused on more on L-arginine and to an extent on what is that? There is a tribulus terrestris. I think these are the two areas where people have focused on as a co-prescription, just like your antioxidant, which improves DNA fragmentation and a better fertilization. So similar to.
So you're saying L-arginine sachet to be given to the man?
Yes, yes.
For erectile dysfunction, not for.
Yes. Along with as a
tadalafil.
It doesn't work.
With tadalafil.
With tadalafil loss.
And for those who want to use it once a week or twice a week or less like that for situational purpose, he's going on traveling and he wants to use it, then such situation, what you do, give L-arginine and both together?
There you give only one tablet. There many a times I use because there, like you said, sympathetic overdrive is there because he is anxious. Either he is meeting a new girlfriend and he wants to perform the best for her and he wants it to last long. So there is a high adrenergic tone. Those are the individuals you should decrease the adrenergic tone, and either I give bupropion for these individuals because it sort of brings them back to normal, or I use simple drug like propranolol, just as an add-on, 10 milligram that day morning, 10 milligram, so that it reduces and brings the sympathetic tone down to normal levels.
And depoxitin for this thing?
Yeah, that of course is premature ejaculation. I never use a combination which is available in the market. That means a sildenafil or a tadalafil with depoxitin, because titration becomes very difficult. So I use it as a separate drug. I don't use combination.
Okay. And there's a last question, that which is in your experience is the best sperm retrieval technique?
In obstructive azoospermia, PISA.
Or TISA.
PISA suffices 95 to 97% retrieval rate. And in non-obstructive azoospermia, if the testicular volume is good, then I go straight away for TESI. I mean, TESI gives you adequate number of sperms. We always put a needle, but TESI is the best technique, I think so. Micro TESI, yes. If you have the expertise, you have the equipment, then micro TESI is a very laborious procedure, not always possible. But the one that he showed, single tubule biopsy, multiple quadrant biopsy, you can, with an 18 gauge needle, we have done that. We are doing that. And we are able to get sperms, enough number of sperms for that particular cycle sometimes.
Sometime in a case of recurrent implantation failure, you want to see, we are trying to see elderly woman above 35 thinking that there is a genetic abnormality. So I'm sure there must be something hidden in men also, right? So doing a useless test like karyotyping, is there something which is coming up in andrology of doing that genomic mapping?
That's coming up. Yes, microarray and NGS is opening up new vistas now, especially in the recurrent implantation failures. We are able to identify
in male also.
In males. to
Okay.
identify new
Areas.
new genes are being identified for that. It is
But it's
ultimately
still-
genetic only.
I would say it's still very primitive. We
Huh.
still don't have answers as to what is the precise ones. But yes,
Okay.
some work is going on in that. In fact, we are collaborating with IBAB for doing some of that work, but it's very primitive at this point.
Okay. 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 So anyway, thank you very much. I think we had a discussion of 40 minutes and we did quite well. Wonderful, Dr. Vasan and Dr. Kishore. Thank you very much, and thank you for technical support, Sprint. And I think Bharat Serum, thank you so much for sponsoring this event. Thank you.
Sir, it
Thank
is
you,
not
Isar.
Bharat
Thank you,
Serum.
Kedar.
Torrent.
Dr.
Torrent.
Gana,
Okay.
it is GoFic.
Go Fig. Sorry. I correct my word. In a day, we are doing three workshops on Zoom. Sometimes it gets confusing. Thank you.
Thank you again. Thank you.